Hey guys, it's me again. Hope y'all really enjoyed that activity. Sorry, my hair. Ooh. Hope y'all enjoyed that activity with patient education. I'm looking forward to getting into the hospital with my group. I'm really having a great opportunity to educate our patients and work on our documentation. So, documentation comes from chapter 26. Again, the PowerPoint slides are loaded in Moodle for you. Not anything real jazzy. It does have good information. I would encourage y'all to just browse through those, look through, make sure you kind of have a better understanding. I'm not going to go into a lot of detail just because each organization is so different with what they require you to document. I'm going to focus on the really important part about documentation. And basically, that is covering your buhonkus. Okay, it's so very important to document. It gives a picture of what you do. It helps assess quality measures, and it helps ensure proper reimbursement. All of y'all have heard about the Affordable Care Act, also known as Obamacare. Y'all have probably not heard about CMS or Centers for Medicaid Services. Y'all probably all have heard about Joint Commission. They're all things that we have all realized over the last 5 or 10 years in healthcare is that standardization is so very important to ensure our patients get what they need. So, all of these organizations have all of these standards that must be met in order for hospitals to get reimbursement. When money comes in, money can go out. When money comes in, you get a raise. Okay, so it's super, super important that we always document appropriately what our interventions are in order to ensure that our organization can maximize reimbursement. But most importantly, those interventions are what are best for our patients. So it's very important that we document those things. Okay, so let's get rock and rolling on this documentation. Right now, documentation may sound fun and exciting to y'all. After your first 3 days as a nurse, you're going to be like, I hate documenting, which is true. You will, but it still plays such an important role in what we do in ensuring that we maintain our safety in the workplace and maintain our licensure, but also that our patients get what they need because we're providing a great picture of what we're doing. Okay, so why is it important? It's a picture of what you do, it's a way to communicate with others. It's so very important. It helps assess quality measures. It allows those people that go in to make sure that we're meeting quality measures, that you're able to do that. They're going to be looking to see that you turned your patient every 2 hours to prevent pressure ulcers. They're going to be looking to make sure that we assessed whether or not the patient ate their food so that we know they have the protein needed to build muscle. They're going to go in and make sure that we're documenting those things. Again, it helps ensure proper reimbursement. A hospital can't run without money. I mean, that's the bottom line. You can't do what you do and have what you need to provide great care to your patients if you're not helping them make money. So it's the nature of the beast. Again, the purpose of documentation is communication. It's a legal document for reimbursement, education, research, auditing, and monitoring. Y'all will soon learn, specifically when you walk in on any inpatient unit, there's always quality measures that are being monitored from documentation. But really, what it does is it facilitates safe, effective, timely, patient centered decision making. Those physicians are going to look in that electronic record. If you wrote a note at 1 a.m. that they awoke in pain, that it was, that the lower tab brought it from a 10 to a 6, and you had to give it 4 hours later and he got it the previous 4 hours, they're going to be able to look at that and know that they need to work on pain management without you having to find them, without you having to tell them, what you need. They're going to be able to read that and see it. That makes it timely, which is important. Common mistakes in documenting. Failing to record pertinent health information and drug information. If it's the first time that you've given a patient a drug, you need to come back and assess whether or not they had a reaction to it. Failing to record nursing actions. Y'all, this is the world's worst. If you have a patient that has a bad outcome, and your nurse manager or your nurse educator goes back in to look to see if vital signs were assessed, if a physician was called, and they don't find any of that, even though more than likely you did it, you're going to be in a world of hot water. Woo, hot, 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 boiling hot water. Okay. A great story, well, an instance, an example of that is when I was a nurse manager in children's, we had 12 cardiac step down beds. And so our nurses one night got a really early morning admission about 2 a.m. And the patient came in. I know beyond a shadow of a doubt that my nurse got those vital signs. That's just what we do. We do it in our sleep all the time. But nothing was written down at all. 20 minutes later, they called a rapid response and the patient was transferred down to the intensive care unit. There were no vital signs recorded in that 20 minutes, though the patient's status changed and was not appropriate on our unit. There were no vital signs recorded. So how does that make, first of all, that nurse look? How does it make our unit look? And it leaves out important information for the physicians. If they came in at that minute 1 on 5C, because they came in through the ER, so they had all the ER's vital signs for the whole 5 or 6 hours she was down there. And all of a sudden, she comes up from the ER and she's not doing well. There's a disconnect. There's not any proof that when she got to us, she wasn't where she needed to be. Does that make sense? Like she should have gone to the unit, even though she came to the 5th floor. There's no proof of that because we didn't get any vital signs. So the patient first of all, wasn't placed where she needed to be, but there's no proof of that. There's no way for us to say, okay, so what happened down in the ER that changed? How did her status change in the ER and what was missed there in order for her to go straight to the unit instead of 5? We delayed treatment. Delaying treatment is the number 1 cause of patient harm besides communication. We'll say it's number 2. Number 2 cause of patient harm is delayed communication. Okay? It's so very important to document pertinent patient findings. There is stuff you can Google on YouTube. I did, preparing for this lecture. Malpractice and nurses being sued. And what the common denominator is not documenting pertinent patient findings. Okay? Failing to record medication administration. In today's world of electronic medication administration or EMR, I know at UMC we have Epic. We scan the patient, we scan the medicine, and we administer it. It's a lot more difficult now to not document administration. But when you still have a paper MAR, it's real easy to forget. So it's always important to document medication administration. Failing to record drug reactions and changes in the patient's status. Again, this comes from my years in management. A patient had an allergic reaction to Rocephin in the ER. It wasn't documented as an allergy. The patient came to 5C, got Rocephin again, had an allergic reaction, was transferred to the unit for closer monitoring. I get the ICARE report. Rocephin has still not been added as an allergy. Okay? That is an example of failing to record drug interactions and reactions. So very, very important. Failing to complete entries, which can happen to the best of us. Y'all, talk about multitasking. Those of y'all with kids know how to multitask. Us kiddos that came straight out of high school to college to nursing school, we think we have to multitask now in nursing school. Yeah, the real world is a difficult transition at times in multitasking. So you'll be typing a note, typing, or in my case, when I started in the dark ages, writing, and you get stopped to go answer a call light or to get a patient pain medication, and you never come back and complete that entry. It's always important to try to remember to do that. Make yourself a note or do something like that. Failing to show discontinuing of medications. This is pertinent, specifically in the ICU. You can turn off fentanyl, or you can turn off Versed, or you can turn off a medication, but not discontinuing it in the MAR. it's going to look like the patient continued to get it. So you have to make sure that you document when you turn medication off or stop medication administration. Okay, electronic medical records. I find it so interesting that I'm probably the last generation of nurses that even remotely know how to document on paper. So I won't even talk about it. It's the dark ages. It took forever. I had to buy pens all the time, even though they are tax deductible, because they're supplies for work, or even finding a pen. I mean, who has a pen? Every good nurse has a pen, an alcohol prep, and a saline flush in their pocket at all times. So we're going to talk about electronic medication record, because that's all y'all are going to ever have to deal with, which is such a blessing for y'all. Electronic medication records, medical records, increase communication, it increases efficiency, it increases quality, and the idea is that all of those decrease cost. There's more real-time communication if you're real-time documenting. You're able to see if a medication's been ordered. You're able to see if an x-ray's been ordered. It really does increase the flow of communication when done appropriately. Interprofessional communication with electronic medical record helps determine quality, cut costs, and improve time management. That's in a perfect world, people. A perfect world. I laugh, old timer here, been nursing for 10, 12 years, that electronic medical record hinders nurse and physician communication, because the physicians can go right to the medical record without talking to the nurse. But the nurse still has to document everything that she sees and everything that she does, which most of the time does not happen. So it's also very important, even though we have this great jazzy electronic medical record that people can check from home, that you don't have to call and talk to somebody to get information, that you still continue to communicate with your physicians and your other healthcare providers. With electronic medical record and with the ease of accessing patient records, brings in the idea of confidentiality. Oh, guys. Oh, patient confidentiality. Oh, if I had $1 for every time I've had to counsel an employee on inappropriate accessing of medical records, I would have $100,000. It is so very important in today's world, and this is a relatively new problem because electronic medical records are relatively new. That anytime you touch a patient's name on a unit census and information pops up at the bottom or a new window opens, you have technically accessed their medical record. So it is so very important that you only access patient records that you have a need to know. Okay? Need to know only. Y'all, need to know. You need to know something. You are going to provide care. You are checking what happened to a patient the previous shift. Do not open a chart unless you are the patient's assigned care provider, or if you're looking up a pain medication, or that you're looking up something to help provide care to that patient. Okay? A prime example of that, again, my time in management. I learned so much. It was only 3.5 years. We had patients that we took care of continually with congenital heart defects. So we would have them from the moment that they were born in the hospital until they went home, and they would come back and forth based on procedures and surgeries that they would have. And our nurses, my nurses, loved our patients so much that if something happened and they went down to the ICU, they would go into their ICU chart and look at it to see how they were doing. You can't do that. Okay? If you're not providing care to that patient, you cannot be in their chart. You cannot be in their chart. You cannot be in their chart. Okay? You can't do that. You can't look at the ER census. My charge nurses were the worst at this. Looking at the ER census and going into patients' charts to look and see if they thought they might be admitted. We can't do that. We cannot do that. Not until they have a bed on your unit can you access their medical record and not violate HIPAA and confidentiality laws. Cannot. I'm sure people have already talked to you about Facebook. Um, don't be posting pictures of patients on Facebook. Don't take pictures at work. The break room, the conference room where there are no patients around, no patient names, no patient documents, maybe. But do not post pictures of you out at the nurse's station. If you stand in by a patient door, you never know what information you put out there from one picture. So we won't talk about that because I'm sure y'all have already gotten the lecture on that, and you will continue to be taught about that through the remaining semesters of nursing school. But confidentiality is a huge thing with electronic medical records. UMC had to pay out millions and millions and millions of dollars because a laptop was stolen from the hospital and it was not protected appropriately and adequately to prevent whoever got that laptop from gaining personal protected patient information. Millions, people, millions of dollars, like millions of dollars. Now, granted, they are a multi-billion-dollar organization, but that millions of dollars that they have to pay out is millions of dollars that they could have used upgrading equipment, getting new beds, getting new scales, getting new IV pumps, new SCD hoses, raises for staff, updating units, replacing broken equipment. That millions of dollars was taken from patient care and given to the government because confidentiality was breached. It is that serious, okay? If people call and say, oh, hey, my grandmother, bless her, I'm so glad I don't work at the hospital anymore. My third cousin from another mother's brother's sister's divorced cousin was in the hospital and she wanted me to check on him. And I'm like, I can go check on him, but I can't tell you anything about him. Why not? I don't understand. Well, because I'm a hospital employee and I cannot provide any information about someone's health to anyone but themselves or their legal guardian. Oh, but Ashley, just tell me how they're doing. No, I cannot do that. You cannot do that. You cannot. I worked on the 5th floor, which was the trauma floor. So I could watch the Friday and Saturday and Sunday night news and see what patients would be on my unit Monday morning. My sweet grandmother, again, bless her heart, has too much free time, would call, oh, Ashley, how was that sweet little boy that got run over by that milk truck? I cannot tell you that, grandmother. I cannot tell you that they're even at my hospital. I don't know anything about them, even though the patient is sitting right beside me in a wagon. You know, you cannot tell any patient information to anyone that does not have a need to know. Okay, standards. How do you know when you document? I honestly don't know what to tell you. It's all based on your policy and your practice at the organization where you work. It also depends on what type of area you're working in. Documentation in the nursing home is different than documentation on an inpatient unit in a hospital. It's different in an ICU. So it's so very important to know your policy and procedures for your documenting at your facility. You need to know when rounds are. You need to know how often assessments need to be done. You need to know how often you need to assess pain, IVs. That'll be all stuff that you learn on the job training, but be prepared to ask those questions. Quality of documentation. Quality. Have you ever heard the idea it's all about quality? Quality is better than quantity. You can have a 4-page nurse's note, but if you're not telling me anything in it, you have wasted your time. I don't need to know 4 pages of information. Short, sweet, and to the point. Slide 10, specifically the speaker notes, have some great information about documenting, okay? Quality documentation sticks to the facts. Nobody cares how you feel. Nobody cares how the nurse feels. You write in short sentences, simple short words, avoid jargon and abbreviations if at all possible. Short, sweet, to the point. Facts. What you observe. Okay. only time you should put subjective information is when your patient tells you something and you put it in quotes. Patient stated, I feel like my abdomen is about to explode. End of quotations. And then you note that you notify the physician and that you gave pain medication, because that's what you do when the patient says their abdomen's about to explode. Okay? So very, very, very important. Okay, methods of documentation, y'all. I keep wanting to say documented. There's a narrative, which is important. It's always good if something's wrong with your patient to have a narrative note. Problem-oriented medical record. The most common that you will see is charting by exception. That means what you chart, the only time you chart is when something is wrong. You don't chart that the breath sounds are clear and equal bilaterally. You put within normal limits because that's the expectation, okay? It's the exceptions that you worry about when you chart by exception, which is the most common form of documentation in hospitals today. In the progress notes, anytime you have something that's an exception that deviates from the standard, you need to write a progress note, or you need to note over in the side corner in the documenting method that the hospital uses. What you hear, what you see, what you feel. Okay? Not emotions feel, but what you feel with your hands. Okay? Many parts of what you're going to be documenting are mandated by CMS, Centers for Medicaid Services, the Joint Commission, and other accrediting agencies. Okay? For each specialist, specifically I use UMC, again, that's all I really know. For our stroke unit had specific stroke information that they had to document. For our asthma patients, we had specific asthma documentation that we had to document. So it's super important that you do that. Depends on the area where you're working, inpatient, outpatient, short stay surgery, long-term care. It just depends. What you document depends on where you work. And all that is typically decided by the organization policies and procedures. That's why I'm not going into a lot of detail about it, because what I tell you now is going to be different in 18 months when you get out of school. Okay. Also, there are some great informatics in nursing slides. Slide numbers 26 through 29. Look over those. Be familiar with the speaker notes. That's all I have for documenting. There are 2 videos that I want you to watch from Nurse Nicole that I've put the links in Moodle for y'all from YouTube. Depending on what time we're running on, Dr. Welch can decide whether or not to show those now or later. Patient education was really the focus of our time together today. We're going to have lots of practice with documenting. We're going to have lots of practice on what to do and what not to do. Have no fear, people. You're going to learn a lot, and you're going to learn a lot quickly, specifically when we get in the hospital setting. I hope y'all have a great day. I hope it's sunshiny outside, not too warm. Looking forward to the cool weather. I'm missing my clinical group. Man, it'll be 2 weeks since I saw ya. I miss y'all, but I'll be seeing y'all soon. Hope y'all have a great afternoon.